Everybody, and thank you for joining the Milestone Test Remediation Presentation. I'm glad that I have some of you join the session, and I hope the others will have an opportunity to watch the recording later. So this session, in addition to being the remediation session, will also serve as a review for the final exam because the topics are similar. So what is the focus of this review? It is domain 5 in the RHIT exam, which is called quality. Okay, so basically in this presentation, I'm going to talk about the remediation itself, some general information about the RHIT exam, study and test taking skills, resources used for review. I'm going to cover some key concepts of the RHIT domains that are covered on the milestone test. And then, of course, if you have any questions, I'll be happy to answer them. And then I'll also take a look at the chat box, and if you have anything moving forward, I'll try to address it right away. So why are we doing the remediation presentation? Basically, we want to make sure that we provide an overview of the domain that you just took a test on last week, highlight some of the content, concepts, and terms, and then discuss multiple choice test taking skill because that's what the RHIT exam will be like. It will be all multiple choice questions. We also want to make sure that we utilize in general the milestone test results as feedback. So as I have selected the areas for review, I also took a peek, of course, at your test performance and some of the questions that were fully addressed or not fully addressed and things like that. Basically, as you start thinking about the end of your, towards your graduation, you're going to start taking the review course, which is called HIT 272L. It's a RHIT exam assessment course. And then, of course, down the road, the RHIT exam, you want to make plans on how you're going to study, what resources you're going to use, and all of these things. So these milestone tests are meant to give you a flavor of the RHIT exam and just kind of get you prepped for it. Okay, so in the real RHIT exam, you will face a little different setting. Okay, it's yes, somewhat similar to this, but it's going to be a little bit different. First of all, you will be eligible to sit for the exam after you complete the RHIT program at the RHI. Okay, so upon graduation with your associate's degree, you will be eligible to sit for the exam. When you take the review course, the HIT 272L, I believe there will be instructions on how you can apply for the exam. So hopefully you will follow those and then follow the process that the RHI offers and provide the information you need to AHIMA, your transcripts pretty much, and then schedule your exam sooner rather than later. Your RHIT exam is 3.5 hours long, and it includes 150 questions. This is a little bit more, actually a lot more than what you're used to answering now. Typically in your final exams, you have in between 30 and 40 questions, right? So you need to really work on the speed, and the milestone tests are designed to serve as a bridge. So you have more questions, less time, but it's not exactly the same as the RHIT exam. It's just trying to get you prepared for it. 20 of these questions in the RHIT exam are called pre-test questions, but you do not know which ones they are. So you treat them all the same, you treat them all equally. What does it mean? It means that there may be a chance that in your RHIT exam, you will see questions and think about, oh, did I ever study this? And it could be that maybe you did not. So it really depends on what those pre-test questions look like. The reason the exam makers include them there is because they want to check their validity and the opportunity for inclusion in future exams. So you don't have to worry about that much. You just want to focus on reviewing as much as you can. All the questions are multiple choice, and they have 4 answering options. And the RHIT exam right now includes 7 domains, and one of them is quality. If you wait too long until 2017, I believe the domains will change, will be rearranged a little bit. The content is not going to be totally different, but the domains will be rearranged, and I believe they will go down to 6. So for right now, that's what it is. So you want to be prepared for that. Hopefully, most of you will graduate this year. All right, so in general, as far as studying goes and the test taking skills, people are different. You know, their retention varies, the memory, the way they study. But in my opinion and my experience, I've been teaching with the RHIT for 11 years and I've taught before that at other schools. If you are systematic and read every day at least about an hour, you improve your chances of doing well. Okay, you want to make sure that you write. I insist a lot on writing things down, whether it's a notebook or flashcards. And then in the discussions, I usually ask for a lot of details because the more you write, the more you improve your retention and memory. And what I mean by writing is not just simply taking a paragraph from here and writing it there. It's really processing the information in your brain and writing about that. Okay. The benefit of this process is that when you want to review something quick and you don't have time to open your books or carry those heavy books, then you will have quick and easy resources to use, your flashcards or a little notebook. Okay, so that becomes really handy too. You need to practice with multiple choice questions as much as you can. There is a textbook you are going to get eventually in your HIT 272L course. It's Schneering is the author for this book, and I have the title in the next slide. And that's full, just multiple choice questions on all domains. As far as reading the questions, you do read them carefully. You should read them carefully, but do not overread them. Okay. The intention of the exam makers is not really to trick people. Sometimes it looks that way, but that's not the real intention. The intention is to make sure that people are able to dissect, you know, what's given, to understand what is really being asked and what information pertains to the answer. Okay, not everything that's given is going to help you answer the question. So just that's what I mean by read it carefully, but do not overread them. And you never leave an unanswered question. Even if you randomly select one out of the 4 options, at least you have some chances, 25% chance of getting it right. And even better, when you use a system of elimination, when you know for sure that a couple of the options are not going to be the correct answer, then you improve your chances even more. If you eliminate 2, then you have 2 left. So that will improve your chances of being right at 50%. Okay, so definitely it doesn't matter how much of a rush you get towards the end. Don't leave an unanswered question. Okay, so this is a slide with the resources I mentioned. So your sales textbook, the one you have now, Horton's textbook, again, the other one you're using in this course, and this is a Schneering one. It's called Professional Review Guide for the RHIA and RHIT examinations. So you want to try to get the recent edition, but even if you go back a year, sometimes 2, it's okay. But once you, again, if you hit the mark when the domains are going to change, then you might want to get that year's edition because you want to make sure you get the latest information on that. Now, some of you, depending on when you started the program, might still have the John's textbook if you purchased the hard copy, and that is fine. There are some chapters that don't quite match with sales. Sales is the newer edition. But if you have that, that's fine. It will also work for this particular domain. So are there any questions before I get into the key concepts? So overall, you know, I just wanted to get a little bit of an introduction in terms of the exam and just the studying aspect of it. All right. So this is the part where I highlight some of the key concepts. It's not going to be a full-blown review of everything, but I've tried to at least make notes of key things that you should be reviewing. So of course, the first thing is performance improvement process, right? The PI process. This is how we started the course. And we know by now that it's an ongoing cycle, and it involves things such as identification of performance measure, what you're actually going to measure, whether it is a clinical aspect or whether it is that wait time in the ER room or a physician's office. You're going to actually measure it. So if we're talking about the wait time, that's the performance measure, right? Wait time. How do you measure it? The measure to measure that, you actually have to clock in when the patient came and when the patient was seen. And that difference between those two times is going to give you the actual timing. Then you can analyze and compare. What does this mean? It means that you take a look at the data you collected. Let's say you did this study for a month and you collected the timing for each patient as they walked into the office, and now you have an understanding of how long each of them waited. Maybe then you run some analysis and do the average wait time, or maybe you do the standard deviation. And then you look at some of the opportunities for improvement. You look at what are some of the other offices doing perhaps, or what do your surveys tell you in terms of customer satisfaction or patient satisfaction. So that's a comparison piece, and you try to identify whether you're doing well or whether there is an opportunity for improvement. And if the latter is determined, then you're going to make changes and monitor that change until you get the desired outcome. But at the center of this is always, never forget, is the customer, in this case, our patients, right? There's three important parts of the process, or this PI ongoing process. Of course, the input, the process, and the output. Again, this was something we discussed at the very beginning of the course. So with input, what do we mean by that? Well, the resources we have at hand. Usually it would be the ingredients. But what are the ingredients in healthcare? We're talking about the equipment we have. We have the staff qualifications, the number of physicians. All of these are considered part of the input. Process, think of protocols and guidelines that are followed in terms of taking care of the patients, or even the flow of the process from the beginning when the patients first sign in the office all the way until they go to the they're seen by a nurse, then a doctor, and then check out. So that's the process. And what's the output? The output might be patient satisfaction, or it might be whether your patients that see your office are healthy or not. Or perhaps their compliance with medications and things of that nature. And then no matter how good of a job you do, there's always going to be some variation. What do we mean by that? Change from the normal, or change from the absolute best. So there's going to be times when you do very well and times that you don't do very well. Why does that happen? There's different factors. Okay, there is common cause variation, and there is also exceptions sometimes. Even if you think about when the nurses, let's say, start the shift and when they end it, and the variation in their performance and their quality of service from one time to another is just the course of the nature and the human exhaustion feel. All of those things might play a role into that. So there are things that you just can't control sometimes, and there's things that you can control. For example, if you notice that the nurses are making more errors, more medical errors, or perhaps medications or certain types of errors towards their end of the shift, and maybe their shifts are 10 hours or 12 hours long, perhaps you could do something to reduce that variation to improve that quality. Maybe you shorten their hours. Okay, just as an example. I'm not saying that everybody does that. Just as an example, when you see that something can be addressed and you identify a trend. Now, when we change something, as we always do in healthcare, there's always something changing. We need to make sure that we manage that change. Any idea how we can manage change, or some of the methods or some of the strategies that are used out there to manage change so people don't get frustrated and don't comply with it? Because the whole point is, when we change something, we want people to adopt it and to comply with what we have changed. Well, definitely communication. I hope you're thinking of communication, ongoing communication, involvement of people during the process of change. If people feel left out, and they don't understand the importance, they're probably not going to have an easy time complying with it. But once they understand their importance and they feel part of a team, they probably will adopt it a little easier, smoother. Okay. In every PI process, chances are that you're going to have teams, whether it's a clinician team or if it's a coding project or an EHR project, you're going to have people from different areas, including HIT or coders or people from IT, physicians, nurses, all of those. So you want to pay attention to the composition. The composition of the team should reflect the needs of the project, the needs of that team. If the project is actually such that it requires a greater diversity, you want to make sure that you capture that and you bring people in from different areas so they can have a say, they can have input on the process. Does it make sense? Okay. I'm not going to bore you with the theorists here, but just make sure that you read a little bit about the 4 quality management theorists, and even more. There's a few more out there. Some of them might be focusing on 0 defect. Some of them might accept some tolerance, some variation, and might say, well, if we can manage 80% of this variation with 20% of our efforts, that would be really great. So they're focusing more on the statistical parts. And some might focus more on the process. So people or these theorists have focused on different things because of their interests. But they all bring something useful to the table. And if you know their theories, then you probably will have an easier time understanding and taking on these projects and becoming a part of a PI team and becoming more successful. Now moving on to the performance improvement tools. There's a number of them, and I've only selected a few for this slide, starting with flowcharts. Flowcharts are process charts, right? They show steps that you need to take to complete a certain task from the beginning to the end. It could be something simple as release of information flowchart. So it would start probably with something such as a request received. You identify or you scan it for completeness. Is this request complete? Yes, then proceed with release of information. Is the request not complete? Not complete? Is the request complete? No. Then in that case, you would follow a different path and try to reach out to the requester and say, we need from you a complete request, and then go from there. So I didn't put an actual flow chart here because I think we've talked so much about them and they're already pictures in your textbook. So you're okay with visualizing that, right? And the same thing for the fishbone diagram. I put them here because they're important and I want you to fully understand them so you can use them in your final exam, whether they are asked in the form of multiple choice questions or perhaps as an essay question when you're given a scenario, let's say, and the question says, tell us, what PI tool might help actually in addressing this type of problem. So the cause and effect diagram, also known as the fishbone diagram, helps in dissecting the problem and trying to figure out what is really the cause of this issue. Is it, let's say, IT? Is it the clinicians? Is it the actual process? Is it the equipment, the system? Okay. Brainstorming, I think everybody knows about brainstorming, and there is still value to it because it highlights the need to bring in input from various departments, from different people. A histogram is also very important because, and I didn't put here all the other graphs because this is particularly related to the analysis piece, okay? Why? A histogram shows the data attached to each other, right? And it has the potential to provide the tool to compare and to analyze. So it's kind of a nice tool to use in performance improvement. Some people use storyboards. Imagine cases where maybe a certain medication error or even a surgical error caused something really terrible to happen with the patient. Even if it wasn't loss of life, perhaps extended length of stay or damage in certain body parts. So that cases like that usually make it on storyboards, and the hospitals try to make a big deal out of those so people can actually get attached to look at the consequences or potential consequences of not following protocol or not checking for everything or not looking at the patient's safety aspects really seriously. Okay, so they have a big impact on people. That's why they're used. And we haven't talked about this much in the discussion area, so I put it here. Benchmarking has to do with the process of comparing how you do in relationship to um, comparable places or facilities that you either aspire to be like or to be close to, or to kind of be in that same range. All right, so once you figure that out, then you monitor your own performance and you can check the others' performance and see how you stand. You did a little bit of benchmarking, even though you didn't call it that, when you did the analysis of general clinic last week. Okay, so again, the idea is to look at how you are performing, what is the expectation, who should you be comparing it with, your performance with, and so on. And then, of course, ultimately going for that. Okay, this is something else we had discussed at the very beginning, and it's still important. The indicators. What are the three major indicators? Well, structure, process, and outcome. So structure has to do with the resources you have available, the facility, the equipment, the organizational structure that you have in place, the hierarchy, the relationship, the types of contracts that are in place with either physicians or other care providers, or the relationships you have with insurance companies, all of those. Process has to do with either the clinical protocols or the policies, the procedures, not the policies, the procedures that you have in place, how you actually do things, right? Outcomes have to do with, just as the name suggests, what is the expectation at the end for certain things? Are you looking at certain death rates to be really low, compliance rates to be really high, and things of that nature? And that's why we have spent a few weeks on calculations, and I'm still posting problems for your review in the discussion, because it's not just a matter of do you know how to do math. It's a matter of understanding your data and knowing how you pair up with other parties. And unless you do some calculations, you can't do that. All right? How do you select indicators? Well, it depends on what is important to you as a facility, as an organization, and sometimes what do you need to be compliant with. For example, for certain core measures, like heart failure or acute myocardial infarction or pneumonia, and you have a couple of these already in your course project for analysis, right? Well, the expectation is to be either 80%, a minimum of 80%, or even higher depending on what the national average is, right? So how do you select your indicator? If the minimum is 80%, but really everybody else is is managing to be at 90%, well, then your indicator is going to probably need to be bumped up and compared to the higher level. Okay, it's not going to be enough to just satisfy the minimum. So as you do your analysis for those selected core measures that you have, you don't have a full-blown report, but just a couple of things, look at that and see how the facility is doing and make sure that you address that as either positive or to be improved in your memo. Here's a little checkpoint for you just to see if you're alive and active out there. So the responsibility for performing quality monitoring and evaluation activities in a departmentalized hospital is delegated to who? And I did not explain this, but this is another way to think about the different types of questions you'll be seeing. So, Director of Utilization Management, Chairman of the Board of Trustees, Clinical Chairpersons of Medical Staff Committees or Ancillary Department Directors, or Chief Executive Officer. So what are your key words? Responsibility, quality monitoring, right? And this is a departmentalized hospital, which means a hospital with many departments. So in a hospital with many departments, this is what I meant earlier by reading it carefully but not overthinking it. So who do you think is going to be the responsible party here? And I see some answers. The correct one is C. Yes. All right. So clinical chairpersons of medical staff committees or ancillary department directors. Okay. So because there's so many departments, and remember early on we established that a quality and performance improvement is done as a team, right? These teams are composed from people from different departments, right? Okay. And this is not to say that the other parties do not have a role. They definitely do. But here it says quality monitoring and evaluation. So they're not going to monitor everything. So the Board of Trustees just wants the big numbers, okay, the summary, the aggregate data. The rest of the details, the chairpersons, the department directors, they're going to have to take care of them. Okay, let's move to another area here with accreditation, licensure, certification. So what is this about? Just making sure that you know the difference between the three. Of course, accreditation is voluntary, but many organizations opt to be accredited because it proves or it demonstrates, it reflects a higher level of quality, and it gives them, so to speak, bragging rights. Because they can say, hey, you know, we have been proven to meet these criteria, or you know, we have reached a certain quality, and others can tell you about that. So what are some of the accrediting agencies? Of course, the Joint Commission, NCQA, the National Committee on Quality Assurance. Think about Det Norske Veritas, American Osteopathic Association, and there's more. Now, with many of these accrediting agencies, if a facility is accredited by them and they have been partners with Medicare, Medicaid, right, they're considered to have deemed status. In other words, Medicare is not going to make them go through another review, another certification process again. So that's a bonus. So let's say a facility is accredited by the Joint Commission and they also want to be certified by Medicare, Medicaid, they're automatically considered to have a deemed status and they get that certification. Now, the Joint Commission is known to use the tracer methodology. And the tracer methodology is used for patients and systems. What does it mean? It means that the surveyors, when they go to the site, to a hospital, let's say, or another type of healthcare facility, they're going to trace the patients and the systems. And they will follow a patient all the way from the registration to being admitted to a unit or transferred to another unit all the way to discharge. Or they'll follow a process in a system. So let's say a physician ordering medications through the CPOE, the computerized physician order entry system. So they're going to see how that functions, how that works. Are they getting the alerts on allergies or drug-drug interactions? And then how is that information, that message going to the pharmacy? Once the pharmacy has completed the order, how is that getting back to the nurse for medication administration? Once the medication administration has been done, how is that being documented in the medication administration record? Okay, so there is a flow here. So it's considered tracing of that process of the system. Medicare has what we call conditions of participations for facilities that are interested in doing business with them. What I mean by doing business is that they can treat Medicare, Medicaid patients and expect to be reimbursed by Medicare, Medicaid. Okay, and we already mentioned the deemed status that comes with the accreditation. As far as the licensing, that is a mandatory process, and it is required for any healthcare facility to operate, and it's done by usually the Department of Health, the state's Department of Health. A few more things that are a little random here. What's a health record? A health record, of course, contains the data about an individual patient, right? And it is considered to be the primary source of data. And then on top of that, we have secondary sources of data, including indexes such as MPI, disease index, operation index, and what else? Physician index. There's also data sets such as UHDDS that's used for hospitals, right? Uniform Hospital Discharge Data Set. MDS that's used for nursing homes or skilled nursing facilities, minimum data set. OASIS that's used for home health. ORIX that's for core measures. Again, you have a couple of those in your course project. So they pertain to heart failure, acute myocardial infarction, pneumonia, stroke, some pregnancy and delivery conditions, and so on. Now, in general, the information that's generated and maintained by in the facility needs to meet the internal and external needs. What does this mean? Whatever you keep and document, you do it for a certain purpose, not just because you have fun with it. Well, you can certainly do that, but you want to justify payment and the expense that is associated with it. So typically you do it because you want it to meet either the facility's rules and regulations and medical staff bylaws, or perhaps the accrediting agency asks you to do it, or perhaps Medicare, Medicaid wants you to keep track of that, right? So that's why you generate a lot of information. One more thing here in the slide, the Healthcare Integrity and Protection Data Bank. This was a result of HIPAA, okay? And it led to the creation of the National Practitioner Data Bank. You remember what the NPDB is, the National Practitioner Data Bank? It's a data bank where information about physicians all over the country is maintained. That includes their education, their specialties, where they went to school, and even cases if there were cases, lawsuits, or certain decisions that were made. Okay, moving on to clinical quality assessment. There are two important parts when it comes to clinical quality: guidelines and protocols. Guidelines are typically short, and they include things such as what should be done at a certain age, or what should be done for a particular disease, or to prevent something such as vaccines or certain diagnostic test at a certain age, and so on. Clinical protocols, on the other side, they're more detailed, and they include certain processes that need to be followed in terms of certain clinical conditions or diseases. For example, a patient comes in with pneumonia, perhaps the protocol says, or it's suspected to have pneumonia. The clinical protocol for that would be definitely do a blood culture and do a chest x-ray, and try to confirm, in other terms, try to confirm pneumonia and what type of pneumonia this is, so you can give the patient the right antibiotic. Or another example would be patient has surgery, do something to prevent thrombosis from happening. Whether you use medications or you elevate the leg, it's your choice, but basically do something to satisfy this protocol. Now, many of these standards and requirements are set by accrediting, licensing, and certification bodies. The second important function in quality management is utilization management, and this includes utilization review, case management, and discharge planning. So with utilization management, make sure that you review things such as screening criteria when the patients first come in and seek a certain service, medical necessity, whether, let's say, that surgery is required or necessary, or whether admission is necessary. Pre-admission utilization review. Should this patient really be admitted for this condition, or can it be treated as an outpatient? Continued stay utilization review. Should this patient stay for an additional 2 days in the hospital or not? Perhaps they should be moved to a rehab unit. Retrospective utilization review. While this is done afterwards, so there is no impact on or no changes would occur for a patient currently at the hospital, it does serve the purpose because sometimes it's just impossible to do all the analysis on a concurrent basis. So some of it is going to be done after the fact. But there is still an opportunity to identify trends and be able to identify problems and then try to address them. Case management is a little bit different, has to do with coordinating and facilitating care. And discharge planning is making sure that the patient has certain levels of follow-up after they're discharged. So the idea is that the job of a hospital does not end when they let the patient go. When they let the patient go, it means that they no longer need acute care, but they might need a different level of care. They might need home health, or they may need to be transferred at a nursing home, and so on. The third important function is risk management. And there is a certain reason, why this activity is important. Every facility, every organization has a certain level of risk. And whether that's associated with its location or the population or the maybe the geographical location of the place. Let's say it's close to a flood zone, or perhaps the risk is that this facility is located in a very poor area where most of the people don't have health insurance, and they end up in the doors of the hospital without insurance and really sick. Or perhaps certain conditions make it favorable for I don't know, fire or other types of hazards. So whatever that is, those risks need to be identified and analyzed. And then usually there is a level of probability that these are assigned. And of course, the ones that have the highest probability take the most attention, but the other ones don't go unnoticed either. And that's how the risk management department comes up with loss prevention and reduction programs, whether that is insurance for certain things, okay, or sometimes training. If, let's say, the risk is anticipated on information, inappropriate disclosure of information. Well, you can get insurance for that, but really the better prevention is to really train your people and be careful when you hire them so that they do not intentionally disclose information inappropriately. Okay, so it really depends. However, can you control flood? Maybe not to the extent you think you would. So maybe you better do something either about backing up your information at another location and definitely getting some flood insurance. And no matter what we do to reduce or even prevent risk, there's still going to be bad things that happen. People will fall, and medication errors will occur, and maybe fire will happen, and flood will happen. That's why there is still a claims management function that needs to actually exist. Now, for any type of incidents that occur in the facility, there needs to be an incident report. These incident reports identify or detail, rather, all the description of what happened as much as possible, who was there when this happened, what were the consequences, who got hurt, and the severity and all of that. And this is never filed in the medical record. They are stored separately. Any questions? Okay. I will ask the question then. Most acute care facilities use this type of screening criteria for utilization review purposes to determine the need for inpatient services and justification for continued stay. Oops, I clicked this too soon. All right, so I hope you understand here the rationale. So the answer is severity of illness, intensity of service criteria. Again, let's look at the question. Most acute facilities use this type of screening, right, for utilization review. So it's screening. How sick are people that are coming to the hospital, right? And what does that? It's the severity of illness, intensity of service. Does that make sense? Out of the options that you have there? Okay. A few more concepts and terms. QiOS, you guys have heard of these, right? Quality Improvement Organizations. They do external reviews. Most of these have contracts, either with Medicare or Medicaid, and they will come to the facility and do different kinds of audits. Peer review, on the other side, is internal. So you have people identified within your facility, whether they're physicians or nurses, and they review the work of other clinicians. Something else that goes into this is physician credentialing. This is the process of delineating the privileges for physicians. So it's the process, it goes through the governing body for approval, and as a result, a physician is either allowed to admit patients or consult patients or do surgeries, certain types of surgeries or all kinds of surgeries. So that's what this means. And it is managed by the medical staff bylaws, but HIM has a role, can play a role in providing data and researching information that they need. I actually did this for many years at Holy Redeemer Hospital in terms of supplying the medical staff with the information they needed every 2 years when they did the physician recredentialing, because it's done at the beginning when they're hired, but then it continues for as long as they have privileges in that hospital. So basically, I would run reports and look at the volume of patients they treated, volume of patients they admitted as attending physicians, or number of surgeries they had, number of medication errors that they had, their compliance with core measures, because we have core measures in general. Let's say a physician is internal medicine specialist and they treat a lot of heart patients, right? Well, they are expected to comply with core measures. Did they give aspirin on arrival when the patient presented with acute myocardial infarction? Yes, no. So basically, I would break down the information from the facility, focus, zoom in on this particular physician and see their particular compliance rate. Okay? This one was discussed earlier. Just take another look at the types of data all the way from nominal to ordinal, interval, and ratio. And there was a lecture on that early, so I'm not going to spend a lot of time on. And this one the same way as well. So we had another recording with the different graphs and their use. Just as a quick reminder, always look at line graph to show trends over time. Bar graphs, usually great for comparisons. You can identify certain trends, but not really for other purposes. Usually for comparison is best. Pie charts are best to show parts against the whole, so composition. Scatter diagrams are best to show relationships. Pareto charts are really great to identify what are the main issues or the most serious issues. Control charts are best used to show when something gets out of whack, out of control. So think of a monitoring device for a patient. Let's say blood pressure monitoring, okay, or pulse or things like that. When does it beep? It beeps if it goes either extremely high and it reaches a certain point, that's a control point, or extremely low and that's that other control point. Well, you can imagine the same scenario for, let's say, the finance department when the bills are getting paid and when they're not, especially when they're not getting paid. Is it hitting that certain control level that they need to be worried about? Because if they're not getting the income in, they will have to worry about how are they going to pay for the labor and the work they're doing. The employees may not be able to get their paycheck if the money is not coming in. Okay, so it's a bit of exaggeration, but that's the idea of the control chart. The frequency polygon has to do mostly with how values are distributed and where do you see the greatest density, you know. All right. And there's more charts, but those are a few that I picked. Now, as far as the measures of central tendency and dispersion, I put them here, but because we have those separate recordings, I am not going to go over each of these. But I do want you to review these all the way from mean, median, mode, variance, and standard deviation. Okay, standard deviation, keep in mind the normal distribution, that bell curve, look at it in the textbook. So when you see the majority of the values, like 99% of the values falling within +3, -3 away from that mean, right? That's considered a normal distribution. However, if you see shifts to the right or to the left, you know that then there is deviations from that normal. Okay, one more checkpoint, and I'm going to make sure I don't reveal the answer too quick. So the board of directors of a 400-bed women hospital receives a report of key quality indicator results on a periodic basis. The report always includes the quarterly C-section rate. This reporting period, they see a rise in the rate and want to know if it is a significant increase. What is the best QI tool for this purpose? I'll give you a second to think about. So we have control chart, Pareto chart, run chart, and scatter diagram. So if we want to see whether this rise is significant, what could be the best tool? Okay, so we have a D answer. Let's see. I think a couple of you are typing. I'll wait for one more. B. Okay. It is actually A. Remember what we just said with the control chart, if it hits a certain point. So how do you know if it is significant? You have to have a certain benchmark, right? And if it hits it, you know it because you would best know by using a control chart. The control chart will have that point. Is it too low or is it too high? In this case, is it too high? What is too high? That would be your control point. Your Pareto chart is just going to stack things, and you just have one variable here. Pareto chart usually is used if you have more than one indicators. Okay. D was scatter diagram. There's two variables. Usually, you know, you're going to see the distribution over time, right? In this case, you would have, let's say, the months and the C-section rate, and you would see that distributed, but there would still not be a point of comparison to identify if it's significant enough. Okay, so that's why the scatter diagram is not really the best option. Does it make sense that control chart is? All right. Okay, in terms of calculations, compliance rates are pretty popular. You're going to see some of those in your final exam. Record request rate, infection rates, those kinds of things. Now, let me go back one more time here. So when we say rate, just to make sure, you may not have formulas for all of these. However, keep in mind actual versus potential. So think, use your critical thinking skills. Let's say you have 100 records and that were requested, and you only released 80 of those on time. So what's your record request rate? It's 80, which is the actual out of 100, which is the potential. So potentially, all of those should have been released on time or requested, yes, on time, or whatever the case is. But the reality is, the actuality is that only 80 were. Okay, so just think about the problem. Sometimes, you know, we tend to overthink and get lost in the numbers, the game of numbers, and it's really not that. It's mostly focusing on what is the issue and how do I make it workable. So math shouldn't be the hardest part here. So that concludes our review. Like I said, it's not a full-blown review, but these are highlights that were based on your milestone exam as well as your final exam. You would still want to go back at your quizzes, take a look at the questions that I'm posting in week 7. They will help you review for the final exam. I have selected certain problems that resemble some of those you're going to see in the final exam. So I really hope they will help you. And the past videos, if you need to revisit those, feel free to revisit those. You have past recordings. I think the only one that did not work was in one of the weeks. I forget which one, but the rest of them should be good to go. If you have any questions, I'll take them now. And again, if you have more questions until the final exam, I'll be happy to answer those as well. You can post them in the discussion area, Q&A area, or you can email me if you feel that you don't want to post it and share it with everybody. So the milestone test, all you need for that is the password. And here's the password. Write it down. Is the word quality. You will put this in and then go take the milestone remediation test. As far as the milestone test, as per the RHIT policy, you will not be able to see the answers there. All you can see is the score. But I did highlight the content here, and that's why this was done this way. Okay? It's just like the final exams that you are not able to see the answers in order to maintain the integrity of the exams moving forward. The formula, keep your formula sheet handy because you might have to calculate death rates and there are formula for those. But again, try to think and use your critical thinking skills as well. You will have plenty of time for the final exam. I don't think that will be an issue. You'll have time to look at your formula and do the calculations and move at a pretty decent pace. All right, then, if there are no more questions, I will, oh, there is one more. Is the final on calculations? There are also calculations, but it's not just calculations. No, it's just like your other quizzes in a sense that there's a lot of multiple choice questions that test you on performance improvement and quality functions and data quality, all of those things that we have been talking about. Okay, but there will also be some calculations. And for those, I am trying to post those problems in the discussion area just to try to get you acquainted with the type of problem. All right, well, I appreciate you joining the session, and I hope this helps, and I hope more will listen to this later. Have a good night, everybody.